Hey guys, so now we'll do the recall session of medicine. You can chat in the comment box because this is like a recall paper. So I'll try to collect some more options from you so that we can have a good interaction. So let's start with the question first. This is a patient was transfused 4 units of blood in 6 hours, after which he developed breathlessness and crepitus. What is the cause? So this is a case of transfusion reaction. So understand this question. The patient is having transfusion of 4 unit of RBCs, right, in 6 hours. So this is due to blood transfusion. There are some complications. Crepitation is there, breathless is there. So what could be the answer? Again, I could get only 2 options. So remember, there are some complication of blood transfusion. So out of this, just I want your inputs. Whether you can see TACO in the option. TACO means it is transfusion associated circulatory overload, or they have mentioned TRALI, transfusion associated acute lung injury. So these 2 options, were they present in the MCQ or not? So understand this, it is not an hemolytic reaction. So this is due to fluid overload, but again 2 options are missing. So I want you to fill these 2 options. Any input, guys? So this is like a condition with massive blood transfusion. A patient can develop 2 important complications, TACO and TRALI, and which are due to fluid overload. Okay, coming to next MCQ, an easy one. Which is the next line of investigation in this patient? So what you can see in this patient, you can see this is the case. You can clearly see it's the case of Graves' disease. Graves' disease or hyperthyroidism. So understand this question. So what is the answer? What do you think, guys? So ideally the Graves' disease, how we make a diagnosis for this? We have an antibody. That antibody is called long-acting thyroid stimulating antibody, or sometimes they can use the word TSI, thyroid stimulating immunoglobulin. So anti-TPO antibody is not the answer, because this is what this antibody we see in Hashimoto's thyroiditis. And Hashimoto's thyroiditis, what we see? We see hypothyroidism, right? Hypothyroidism. Thyroid troponin levels we don't do to make a diagnosis of Graves' disease. So what is the answer here? We do thyroid receptor antibody. So answer for this question is thyroid receptor antibody. So we make a diagnosis by LATS, TSI or TRA, thyroid receptor antibody. Okay, coming to next MCQ. So this is like you can see a clear-cut question here. It's like an interesting case. If I start with this female patient with hypertension, tremors, neck swelling. So there's hypertension, tremors, neck swelling, and known case of asthma. ECG finding is suggestive of atrial fibrillation. So again, like it is an MCQ where they are giving you 3 features. First disease that patient is having is asthma. Second thing, you can see the patient is having hypertension and tremor. And there is neck swelling. So this neck swelling, probably this could be goiter, right? Or it could be a thyroid tumor, right? Now understand this question. What they are telling you, ECG is having atrial fibrillation. So this is like a case of a patient who is having hypertension, tremors, right? Known case of asthma, and now developing atrial fibrillation. So what drug we will use? So understand, this could be a case of a thyroid storm, or it could be, understand this, AF. AF you need to manage here. The main concern is not a thyroid disease. Main thing here is you have to treat atrial fibrillation first. So starting with a non-selective beta blocker, propranolol. Patient is a known case of asthma, so propranolol is contraindicated. Coming to PTU we can use. But again, first thing what we have to settle is atrial fibrillation. So now ideally the answer for this question should be butyrate or amiodarone, because how we manage atrial fibrillation. But these 2 are missing in the option. So what is the drug that we have? We have diltiazem. Esmolol is also a beta blocker, so we'll avoid this in patient of asthma. So answer for this question will be diltiazem. Diltiazem is a calcium channel blocker, and this is also used to terminate atrial fibrillation. So like we have 4 class of drug: class 1, class 3, class 2 and class 4. So understand this, class 1 and 3, these are the drugs which are controlling the rhythm. We call this rhythm controlling strategy. This rhythm controlling strategy, this is used to treat the acute cases. Like we have drugs like amiodarone, ibutylide. Class 2 and 4, these are the drugs which are having rate controlling strategy. So they are more safe. compared to class 1 and 3. Clear? So answer for this question will be deltiazem. Okay, now see a patient is presenting with respiratory distress. There is respiratory distress, JVP showing large A wave. So this large A wave you can see whenever you will see the atria is closing against a closed wall. So this large A wave, classical thing, large A wave will see in a lot of conditions, but here you can see a mid-diastolic murmur. So many of you have marked the answer. So clearly in atrial stenosis you will see systolic murmur. In mitral regurgitation you will see systolic murmur. So answer should be either A or B. Now if you see mid-diastolic murmur, you can also see in a patient of MS. But mid-diastolic murmur with large A wave, these are feature of TS. So answer for this question will be tricuspid stenosis. Tricuspid stenosis, because this is like large A wave in JVP and along with mid-diastolic murmur. So this is seen in patient of tricuspid stenosis. Okay, let us see the next question. A poor female eating only rice and pulses. So this was the interesting line. Eating only rice and pulses means no non-veg food. Pallor, cheilitis. Pallor is there means hemoglobin is less. Cheilitis means it could be iron deficiency, it could be B12 deficiency. Then they are mentioning sensory touch and proprioception lost. Means neuropathy. So you all are knowing like this is like a neuropathy. Then you can see UMN weakness. So this is a case of SACD, subacute combined degeneration of spinal cord, and that is seen in a patient of vitamin B12 deficiency. So classical case. Okay, if I could not get the fourth option. So ALS is amyotrophic lateral sclerosis. So this is like due to hexanucleotide repeat, where you'll see both UMN and LMN lesions, but the pallor and cheilitis are not seen. So these are the hint in the MCQs. Again, it was a tricky paper. So they have collaborated biochemistry with medicine. Multiple sclerosis, you will not see cheilitis, pallor. You can see inflammation. You can also see sensory touch and proprioception, but UMN weakness also you can see. But remember, this pallor is the classical hint in the MCQ. That is, it is due to some deficiency. Then you can see eating only rice and pulse. These are the two important hints. So answer for this question is SACD. That is due to B12 deficiency. Clear? Okay, coming to next question. This X-ray was given. So in this X-ray, what you can clearly see in the right side a consolidation. So this is a right middle lobe consolidation. So this was an X-ray given, an easy question for you. So most of you have marked this question correct. Coming to the next one. A patient came to emergency who took 100 tablet of aspirin. 100 tablet of aspirin on ABG. pH is reduced. Right? What is the immediate management? So understand this, N-acetylcysteine. This is used in antidote of PCM toxicity, not aspirin. So this is like a classical case of salicylate poisoning. In salicylate poisoning, what we can see acidosis. So what we have to do alkalization of urine by using soda bicarb. Clear? So fourth option I could not get, but again a straightforward question. This is like a case of aspirin toxicity, which is managed by alkalization of urine. This is like a session where you can comment in the comment box, so that we can add some more options and we can rectify the question, so that you can get a proper recall. Okay, let's see the next question. In hot summers, a laborer while working in the field collapsed. A laborer, so this is the hot summer is the first hint. Laborer, then pulse rate is 110, but a tachycardia, temperature is 104, means fever. Decrease skin turgor. So understand this, skin turgor is lost. It means this is a sort of a dry skin. A dry skin means patient is dehydrated, and this is the classical case of heat stroke. A classical case of heat stroke. So in heat stroke, can you see red hot skin? Yes. Do we see tachycardia? Yes, we see. UVC, hypotension. That's why patient is collapsing. Sweating, remember, sweating can be seen in another. So remember, sweating is a feature. Sweating you can see in exertional heat stroke. Sweating you can see in exertional heat stroke, and this exertional heat stroke is seen in young person. This is the case of classical heat stroke. So in classical heat stroke, remember, sweating is absent. So you can see decreased skin turgor, that is giving you a hint to mark the correct answer, that is sweating. Coming to the next one, a patient is having mesothelioma. So mesothelioma, when this comes to your mind, automatically you remember mesothelioma is classically associated with asbestosis. So in asbestosis, remember there is a risk of two cancer. The most common will be bronchogenic adenocarcinoma. This is most common one, but most specific will be mesothelioma. Even in the last year exam, there was a question on mesothelioma. They have asked the tumor marker called retinine. So easy one, mesothelioma. Am I clear, guys? Okay. Coming to next, you can see this ECG. ECG is given. What is the best treatment for this condition? It was, I think, the cause was asked, not treatment. So understand. So in the ECG, you can see there is tall T waves. So when you see tall T waves, what you can see in the tall T waves? You can see tall T waves. These are due to hyperkalemia. So hyperkalemia, generally diuretic, they will cause loss of potassium, except potassium sparing diuretic. Metoprolol beta blocker. So generally remember this, spironolactone, ACE inhibitor, ARBs. These are the ones. ACE inhibitor, ARBs, they will cause a mild to moderate hyperkalemia. So fourth option I could not get. So answer for this question should be spironolactone, because it's a potassium sparing diuretic, and this will lead to more potassium. That is why what we get ECG changes like we see in hyperkalemia. Okay, next question, sweat chloride test. Sweat chloride test, where we do. So remember, this is an easy one. Again, sweat chloride test we do to make a diagnosis of cystic fibrosis. So this is the easy one. Sweat chloride test, a direct question to make a diagnosis of cystic fibrosis. Coming to next MCQ, an IT engineer. Patient present with complaint of hematemesis and melena. So means patient is having both upper GI bleed and lower GI bleed, right? History of epigastric pain from long time. So now see, first hint in the MCQ is there is both type of bleed. And remember, the most common cause of both type of bleed is peptic ulcer disease. Most common cause of melena, if you ask me, most common cause of upper GI bleed, hematemesis, if you ask me, that is peptic ulcer disease. Then he is having epigastric pain. So epigastric pain is a common feature of peptic ulcer disease. Then he is taking alcohol occasionally, so alcohol will increase. So many of you confuse the question by seeing the word alcohol. He is also taking aspirin. And aspirin and NSAIDs, these are common cause of peptic ulcer. So Mallory-Weiss, some of you have marked the answer. It's not the answer, because Mallory-Weiss is seen in alcoholic. It is just a mucosal tear. In Mallory-Weiss, you will very rarely you will see melena. Melena is usually not seen, and there is no relation of Mallory-Weiss with aspirin. Variceal bleed is seen in chronic alcoholic, not in episodic or occasional alcoholic. Is it clear? Variceal bleed is a sign of portal hypertension, and portal hypertension patient will develop in chronic liver disease, which is seen after chronic alcohol abuse. Means patient is drinking alcohol from 15-20 years, right? So this is not the answer. So the answer for this question will be peptic ulcer disease. A patient from Delhi. So many students, they have just seen the word Delhi and they mark the answer dengue. So it's not like that. You can see the question. There's high grade fever. In Delhi, malaria is also very common. Chikungunya is also common. Fourth option I could not get. So like many of you are telling, like fourth option was typhoid or scrub typhus. So CBC report, WBC count. In CBC, what we can see, WBC count is 3000, platelet count is 20,000. So what could be that diagnosis? So understand this, when nothing is mentioned, they are talking about thrombocytopenia and high fever. So this is the classical presentation that we see in a patient of dengue. Okay, if some of you are knowing the full question, you can give your input so we can rectify the question later on. Am I clear? Okay, usually patient with dialysis developed hyperkalemia, but sometimes they develop headache, nausea, vomiting, right? This is like an example of dialysis disequilibrium syndrome. So what is dialysis disequilibrium syndrome? Understand this. This is seen in those who are having dialysis for the first time. A person who is having dialysis for the first time, they will develop this, right? Now, this syndrome, how we can prevent? Here what we see, the patient can develop cerebral edema. So that is why we advise every patient with CKD to have a short. This can be prevented. This can be prevented by a shorter first session. So generally dialysis will last for 4 hours. So normal duration of dialysis is 4 hours. So Here what we do, first session is shorter, that is for 2 hours, to prevent this dangerous complication, because here patient can develop cellular edema, and once patient is developing cellular edema, then we have to give osmotic diuretic, that is mannitol. In that case, we have to give mannitol. Okay, then there is a question, a patient is taking anti-gout medication. Okay, like some students said like it was given acute gout. So let me correct this, acute gout. A patient was having acute gout. Which drugs work by inhibiting synthesis of uric acid? So many of you are thinking in acute gout we don't give allopurinol. The question is simple. They are asking you like understand this in acute gout and chronic gout. In acute gout, what we give, the main thing is we have to give NSAIDs. Then we can use colchicine, and very rarely we can use steroid. In chronic gout, what we give xanthine oxidase inhibitor. Xanthine oxidase inhibitors, like we can use allopurinol, febuxostat. Allopurinol, febuxostat. And what else we can use? We can use rasburicase. Now understand, and then we can use uricosuric drugs. So see the question, when you see the question, like many students are thinking, why answer is not diclofenac? So diclofenac is just a painkiller. This will not decrease uric acid. Simple. Okay, coming to probenecid. Probenecid is uricosuric drug. So uricosuric drugs, what they will do, they will remove uric acid out of the body. We call them uricosuric, like probenecid, sulfenpyrazone, right? Colchicine is mitosis inhibitor, so this will stop the cell proliferation. So only option what we are left with, allopurinol, it is xanthine oxidase inhibitor, and this will decrease uric acid production. Now many of you are thinking here, if acute gout is given, then why answer is allopurinol? The reason is, a person with chronic gout, suppose a person is stable with gout, he is not having any symptom, he is taking his medication, is not having symptom, but suddenly he is taking alcohol. So this chronic gout patient can come to you with acute attack. Then you have to give allopurinol. Okay, like even some students, they are mentioning like uric acid level was normal. Then why it is gout? When uric acid is normal, why it is gout? This uric acid value you are seeing in serum. So remember, when entire uric acid is going into your joints, so in blood, of course, this will be normal. So remember, uric acid in the blood can be normal, it can be increased, it can be decreased. This is a line from Harrison. You have to remember this always. Uric acid can be normal, it can be increased, it can be decreased. So how we make a diagnosis? By synovial fluid. We don't make a diagnosis by just saying serum uric acid. Okay, next MCQ. A chronic alcoholic patient with confusion and ataxia, unable to move his eye outward. On examination, there is 6th nerve palsy. What is most probable diagnosis? So delirium tremens is a state that is seen in alcohol withdrawal. So again, this is a complication seen when we stop taking alcohol, where patient will develop hallucinations. Nothing is mentioned like that. So remember the mnemonic GOA. So patient is having global confusion, ophthalmoplegia, right? You can see ophthalmoplegia, then you can see ataxia. So this is a classical case. Triad is given, GOA, global confusion, ophthalmoplegia and ataxia. So this is a classical example of Wernicke's encephalopathy. A classical example of Wernicke's encephalopathy. Hypertensive patient is diagnosed with subarachnoid hemorrhage. So in subarachnoid hemorrhage, you can see BP is 160, 110. What is next best step in management? Okay, now understand this. Immediate nimodipine therapy. So BP is not that high. BP is not that high, so immediate nimodipine is not recommended. Urgent surgery, again, urgent surgery we will not do. We will do surgery if it is a big bleed, but later on. Mannitol, there are no signs of raised ICP, so there is no point of giving mannitol. So this patient, the ideal answer should be, first we should do angiography and we can see what we can do further. So is it a candidate for clipping, or what we have to do in this patient? Clear? So surgical modality of treatment we decide only after angiography. So answer for this question will be angiography. Okay, coming to next MCQ. Try to answer, guys. Anyone? If you see a patient present with, I know like you guys are tired now in medicine, many of you don't remember the MCQs. But we have tried to collect a few of them. So try to answer next one. A patient present with ptosis. A patient present with ptosis, shooting pain in the arm. Cough and hematitis. What is the cause? So you can see there is a tumor. This tumor is called Pankos tumor. So Pankos tumor is a tumor that is located in the apex of lung. So this tumor is located in the apex of lung. So this tumor is located in the apex of lung. So this tumor is located in the apex of lung. So this tumor is located in the apex of lung. So Pankos tumor is a tumor that is located in the apex of lung. So Pankos tumor is a tumor that is located in the apex of lung. So when this tumor is located in the apex of a lung, this will compress the ganglia. So that's why patient can develop something called Horner syndrome. So Horner syndrome feature, or you can see here, is ptosis, right? So this is like Horner syndrome patients developing. This is a complication that we can see in Pankos tumor. I could not get the exact MCQ. So if you have other input, but answer for this question is a clear-cut MCQ, Pankos tumor. Clear? Okay, next one. A 78-year-old lady complained of memory loss, staring at empty places, visual hallucination. Suddenly died. Autopsy showing Lewy bodies. So what is the answer? Try to answer this question. What do you think? What is the answer for this question? Yes, try to answer. Okay, the clear cut here is, you can see memory loss. So it's a case of dementia. Staring at empty places, visual hallucination, and Lewy bodies. Okay, so if you see this question carefully, then you can notice here prion disease. In this prion disease, you will see there is loss of memory. You can see sudden death, but Lewy bodies are not seen. In prion disease, what we see spongiosis of neuron. Spongiosis of neurons. Can we get memory loss? Yes. Can patient get that staring spells? Yes. Can we get hallucination? Yes, but we will not get Lewy bodies. So this is not the answer. Alzheimer disease. In Alzheimer disease, you will get memory loss. Yes. Hallucination, unlikely. Lewy bodies, no. Instead of Lewy body, we get Hirano body. Hirano body, not Lewy body. Huntington disease. Do we get memory loss? Yes, we can get. Can we get hallucination? Yes. Lewy bodies, again, no. So Huntington disease is not the answer. So ideal answer for this question should be, which is not given the option. This is a case of DLB. DLB means dementia with Lewy body. This dementia with Lewy body is a part of Parkinson plus syndrome. Parkinson plus syndrome, right? And Lewy bodies we also see in Parkinson disease. So this is a case of Parkinson plus syndrome. So answer for this question should be A. Clear? Option A. Okay, next you can see this question like again. Okay, this was mentioned with decreased participation in daily activities. Okay, that is like patient is having anhedonia, right? He's having one more thing which I can add in this MCQ is this patient is having anhedonia, right? Loss of interest. Okay, this was a question, good question. You can see cola colored urine in a patient with sudden increase in serum creatinine from 2 to 4, and biopsy is suggestive of precrescent. So what is the diagnosis? So like many of you mark the answer PSGN. So understand these options were like this: PSGN, RPGN. I know these two options, but I'm guessing the other options can be MGN, MPGN. So understand this, even it was mentioned subepithelial humps were present or not. So understand this, this is a case of PSGN. I agree. Now some of you are thinking why crescent is given. Then we have marked the answer RPGN. PSGN can complicate to form RPGN. So RPGN is nothing. RPGN is a complication of other nephritic syndrome. So we have three types of RPGN. We have type 1 RPGN, we have type 2 RPGN, and we have type 3 RPGN. Type 1 RPGN will have linear deposit. Type 2 RPGN will have granular deposit. And type 3 will not have any deposit. What we call this pauci immune. So just again I am writing type 1 is called linear deposit. So patient will develop RPGN is nothing, it is a complication of other nephritic syndrome. So linear deposit we see in a person who is getting RPGN after good posture. So when good posture syndrome convert into RPGN, we call this type 1. When other nephritic syndrome, other nephritic which means PSGN, IgA nephropathy, right, Alport syndrome, when they convert, we call this type 2. And type 3 we call this pauci immune. So in type 2 what we have granular deposit, and in type 3 what we call this pauci immune. Pauci immune means there is no deposit, nothing is there. So no deposit means it is a vasculitis that is converting into RPGN. So that is like Wegener's disease, polyarteritis nodosa. So when they are converting, that is what we call type 3. So answer for this question is RPGN. Because this is now a PSGN. Just by seeing cola colored urine, don't mark the answer PSGN. It's a PSGN that is converted already into RPGN. Which RPGN? Type 2 RPGN. This is the best answer. Clear? Okay, coming to next one. And a patient planned for cardiac surgical procedure, easy one. Which of the following is preferred antibiotic? Which of the following is preferred antibiotic? So what do you think preferred antibiotic? So following is preferred antibiotic. This is cefazolin, easy one. Preferred antibiotic is cefazolin. Okay, coming to next one. A patient with arrhythmia on antiarrhythmic drugs. Following can cause pulmonary fibrosis. Again, a pharmacology overlap with medicine question. A pharmacology overlap with medicine. So what do you think? So answer is imidazole. So imidazole, bleomycin, busulfan, these are few drugs which are known to cause pulmonary fibrosis, right? So sotalol, verapamil, quinidine, these are not causing any type of pulmonary fibrosis. So answer is imidazole. Other side effect of imidazole, you should know that it will also cause thyroid dysfunction. Okay, then there was a question on peripheral smear with history of DIC. History of DIC, peripheral smear is given. So it was like showing presence of these type of rods. These rods are called oil rods. These rods are called oil rods. Oil rods, where we see generally what we see oil rods in M3 ml. We can see in any ml, but maximum oil rods you will see in patient of M3 ml. M3 ml is also called as APML. APML means acute promyelocytic leukemia. Acute promyelocytic leukemia, this is seen due to translocation 1517, because at this translocation what we have mutation of a gene called RAR gene. RAR means retinoic acid receptor gene, and this how we manage this by giving ATRICE, all trans retinoic acid. Okay, again this gout was the hot favorite topic for the season today. So gout was the favorite topic. I think there are around 2 to 3 questions in gout was asked. So 45-year-old alcoholic patient present with pain in great toe. Examination, uric acid is normal. I told you, now people are telling me uric acid is normal, so no gout. It's not like that. When uric acid is more in the joint, so when entire uric acid is going into joint, of course in blood it can be normal. I am repeating this thing. In gout, uric acid is mostly normal, trust me. So answer is gout. It's the classical case. Alcohol will precipitate that attack of gout. Great toe means this is first MTP. The most common joint involved is first MTP. In pseudo gout, you will see the most common joint involved is knee joint. So I don't know what other options. So maybe other option could be septic arthritis. So let me say septic arthritis, there should be history of high TLC fever. Then I can say there can be an option of reactive arthritis. WBC present in synovial fluid. Again, the WBC in synovial fluid, that is suggestive of gout. Right? It is like a gout attack. A gout attack is precipitating in the patient. That's why patient can develop WBC more. Clear? What else was mentioned? Reactive arthritis. Is it clear? So understand, sometime what happen, gout patient, they can develop high TLC. They can also develop increase in TLC. That's very common in gout. So it's like a chronic gout patient who is coming to you with acute flare. We call this gout flare. Clear? Reactive arthritis, this can affect many different types of joint. There should be history of some urethritis. There should be history of some conjunctivitis, which is not given. Septic arthritis and pseudo gout, most common joint in both the cases, knee joint. Right? And uric acid level, remember, can be normal. Okay, coming to next. This was a question on omapatrilat. So answer, I have seen the question like which drug is having dual mechanism of action. So remember, answer for this, that question is omapatrilat for sure. Omapatrilat. Again, this I have discussed in pharmacology also. So coming to this, this was the question, management of decay. This is a question which they are asking in NEET PG question from past 3 years. Same question. What we give? So first is what we give. First choice will be IV fluid, followed by regular insulin. No short acting, long acting insulin. What we give regular insulin because it's the only insulin that we can give IV. So what we do whenever a person is coming with decay, we give like 200 to 300 ml of fluid start. Then we continue IV fluid. We continue IV fluid and we give insulin bolus at the rate of 0.1 unit per kg body weight, right? Suppose if my weight is 80 kg, so you have to give me 8 units. 8 units. Clear? 8 units. Okay, next is was an easy question, Koplik spots, where we see Koplik spots, we see Koplik spots in a patient of measles. Easy one. Okay, then there was a question again, a clinical case was given. So smear negative. Smear negative means sputum for AFB. Smear is negative, X-ray is positive. So whenever you see this, so what is the next step? So understand this, smear means that is coming from the sputum. So sometimes some TB patient, they can have a small cavity. So small, if cavity is small, this cavity will have less sputum. If cavity is big, this will have more sputum. So bigger the cavity will have more bacteria. So the test is having high chance of being positive. So you need more bacteria for the test to be positive, and sometimes like it is not having enough sputum. Is it clear? So how we can confirm this? Remember, always when you see this kind of finding, the next test is CB naught. Next test is CB naught. I don't know other options and I don't want to know because the answer is CB naught. Clear? This is cartridge based nucleic acid amplification test. So that is the next test that we do in this patient. Is it clear? Okay, pellagra, easy one. Again, an easy question on pellagra. Pellagra, there was a question like 3D, you know, diarrhea, dementia, dermatitis, and sometimes they give 4D, that is death. So easy question came in exam, biochemistry overlap. Okay, then there was a question on ankylosing spondylitis. So again, straightforward question. History was given. Like again, I could not get the exact question. Like a young person who is having backache, right? Stiffness in the back, which is more early in the morning. So that is ankylosing spondylitis. So answer is ankylosing spondylitis. Then there was a question on Glasgow coma scale. So again, this is an easy question. These are topics which they tend to repeat every time in the exam. They ask this type of questions. Okay, now this was a question. 64-year-old accidentally diagnosed with increased WBC. A person who is having high WBC count, which was diagnosed accidentally, right? Next investigation. So this is like a leukemia. So this is like old patient. So this could be CML, this could be CLL. But it's mentioning there, they are showing here smudge cells. So when they mention here smudge cells, this is the case of CLL. So in CLL, how we make a diagnosis? We make a diagnosis by doing flow cytometry. Simple. BCR ABL phenotype we do for, generally we do this for CML and we do this for ALL. Right. Bone marrow aspiration we will not do because we can do this later. Once flow cytometry is negative, in that case we can do this. Okay, chronic smoker with cough and hypercalcemia. So understand this, hypercalcemia is the hint. Hypercalcemia means there is more calcium, that is due to PTHRP. Parathyroid hormone related protein, PTHRP, and this PTHRP is the one that because of this hypercalcemia patient is developing grade 4 clubbing. Because of this patient is developing grade 4 clubbing, and this grade 4 clubbing, we have a name for this hypertrophic osteoarthropathy, and this is classically seen. This is classical seen as the paraneoplastic symptom in a patient of squamous cell lung cancer. Squamous cell lung cancer. Clear? Paraneoplastic symptom of squamous cell lung cancer. Okay, child with petechial rash, urine showing owl's eye. So this was the question which you all were waiting for, and I think this is discussed in pediatrics as well. So this is like a case of CMV, easy one. A case of CMV, cytomegalovirus. A patient with anemia and jaundice, platelet count is 2.5. So again, there was a slide given where which was suggestive of spirocytes. So spherical RBCs were given. So spirocytes. Okay, so I got two answers from a student. So age was not mentioned. Anemia is there. So now see the question. Anemia is there. Jaundice is there. So anemia means hemoglobin is less. Jaundice means hemoglobin will convert into bilirubin. So that's why jaundice. So it's a case of hemolytic anemia. It's a case of hemolytic anemia. Now hemolytic anemia and spirocytosis you will see in two types of anemia. So the most common cause is AIH, autoimmune hemolytic anemia. The second is you can see this in hereditary spirocytosis. Hereditary spirocytosis. So these are the two options. So if option is given direct Coombs test, so next investigation I think was asked. So direct Coombs test, direct or indirect Coombs test, what we can do for AIH. But if it is a question of hereditary spirocytosis, then some students are mentioning like it was not in the options, then answer will be osmotic fragility test. Osmotic fragility test, right? We can do osmotic fragility, and even nowadays what we have different tests like ACTA cytometry. So just you have to give me the options so I can give you the correct answer. But this was the question that came in exam. Okay, retroperitoneal bleed with bilateral pain in the knee. So this is like pain in knee and swelling. So okay, patient is having retroperitoneal bleed and swelling. So it's like hemarthrosis. So when you see the word, understand this, petechia, purpura, these are seen in platelet disorder. That is a disorder of primary hemostasis. Hemarthrosis generally we see in a patient of secondary hemostasis, that is in clotting factor disorders. So in clotting factor disorder, like it could be hemophilia A, B, C. So Hemophilia A is due to factor 8 deficiency. Hemophilia B is due to factor 9 deficiency. So understand this, the question was given like that. So this is a patient who is having factor 8 or 9 deficiency, a classical case of hemophilia. Good prognostic factor for CA breast. So we have different prognostic factors. Out of this, remember, the most important generally what we test is ER, PR and Hartinio. ER, PR, Hartinio. So if ER, PR is positive, if ER, PR positive, that is having good prognosis, right? If HER2/neu is positive, and that will show a decent response with a drug called trastuzumab. And even if ER, PR is positive, you don't have to use trastuzumab. This will show decent response with other drugs like tamoxifen. But if it is a case of triple negative means all these are negative, that is having worst prognosis. That is having worst prognosis. So understand this question. Good prognostic they are asking. So answer for this question is ER, PR. So correct answer for this question is ER, means estrogen and progesterone receptor positivity. Clear? Okay, then there are a few more questions. So just I'm writing these MCQs that they came in exam, so you can get an idea what are some other questions in exam that came. So nearly 40 questions I have discussed. So but I can say there are a few more questions. So starting with the first one, like I'm getting some messages from the student. They are giving the questions. So let me see what are other questions that came in exam. Okay, so there was a question on sunflower cataract. So you all know this question. So like on ophthalmology. So this Dr. Shashwat sir will discuss this question, an easy one. Sunflower and Wilson disease, right? Okay, then there is a question like hepatitis B. So again, I'm getting a question. Try to correct me. A patient is having hepatitis B, right? With high viral load. With high viral load, what drug you will use? Options are lamivudine, interferon, tenofovir, or interferon plus lamivudine. So understand this, right now what we recommend is hepatitis B treatment is recommended when LFT is increased by more than twofold. When LFT is increased by more than twofold, and you see patient like AST, ALT, they are increased by more than twofold, and you see HBV DNA, the copies are more than 2 into 10 to the power 3. Or if it is like a person who is in cirrhosis form, then 2 into 10 to the power 4. So in that case only we start the treatment. And OFT is osmotic fragility test. Okay, one more thing was given. HBe antigen positive was given. Okay, let me add this. HBe antigen positive, HBs antigen positive. So understand, this is like HBs antigen positive means a virus entered. HBe antigen positive means it is infective. Okay, let me add one more thing here. 10-year-old. That's good thing you are giving your inputs. So remember, whatever it is given here, I think this was also mentioned. HBV load was more than 2 into 10 to the power 5. This was given. This was the HBV load, HBV DNA value. So when you see this, the treatment is we have to give one drug. So in hepatitis B, we follow monotherapy. So answer should be either tenofovir, right? Or we can use entecavir. And I can give you assurance, both cannot be in the option. So you have, in the examiner, they have given only one. Is it clear? So answer is, I think tenofovir. Clear? Okay. Any other questions you can ask me? I will answer all the other questions if you have. Yes. Any other question? This was question 43. Anyone? You can give your questions. Yes, guys. You can give your questions. Okay. There was a question on like Wernicke. We have already discussed. What else? So this was the medicine part. Again, the paper was simple. Okay, brown ring on eye. What test for assessment? Serum ceruloplasmin. Brown ring. Then what test you will do for assessment? It is serum ceruloplasmin. If it was in the option, serum ceruloplasmin, was it given in the option? If it is given, this is the answer. Any other questions? If it is given in the option, then it is the answer. It's a case of Wilson disease, and how we monitor like serum ferroplasmin level. If values are more than 5, it is considered positive, but more than 15 is considered significant. Right? So remember this Wilson disease, it's a case of Wilson disease. So serum plasmin we try to check always, and we try to keep this in a normal level. Pituitary tumor removed, one question. Okay, what was the question? Pituitary tumor removed. The surgery that we do for pituitary tumor is transpenoidal resection. Okay, you can give post-operative, there is polyuria. Okay, suppose this is a pituitary gland, this is hanging in an area called sella turcica, and you have removed the tumor. When you have removed the tumor, right? So what is happening? There is you have removed the tumor in the pituitary. So ultimately you are creating some damage. Remember, neurosurgery itself is a complication, and now patient is having polyuria. Polyuria means what you have triggered? You have triggered something called diabetes insipidus. So it's the case of a central diabetes insipidus, right? It's a case of central diabetes insipidus because there is damage to hypothalamus pituitary axis. So post-op there is polyuria. Like we have this type of patient in practice as well. Like even I had a patient who had subarachnoid hemorrhage after surgery. Okay, point maker, just wait and observe. Yes, it's the case of diabetes insipidus. It is a classical case of diabetes insipidus, guys. What else? Okay, so I think here we will conclude. So you can comment in, you can write the options in the comment box. So later on I will give you a detailed discussion with all the good options. So it is like resistant hypertension was also asked, right? Resistant hypertension was also asked. So it is like resistant hypertension. This was a hypertension which is not controlled by a 3 or more different class of antihypertensive drug. That must include diuretics. Which diuretic? Thiazide diuretic. So okay, I'm adding more thing. Treatment asked for this complication, for which hitarth, for which complication they are asking treatment? Resistant hypertension, not controlled by 3 or more diuretics. Treatment for which? Okay, for diabetes insipidus, what we give? Yes, come on, what we give? Tell me the answer. What we give? We give desmopressin. So this is a central type. So that's why what we give? We give desmopressin. This is resistant hypertension not controlled by 3 or more diuretic. Not lifelong, it is for short duration only. Right? Okay, clonidine withdrawal was asked. Clonidine withdrawal hypertension was asked. So that is called rebound hypertension. Right? So that is called rebound hypertension. Okay, guys. So you can give your opinion in the comment box. So later on we will have a fresh session for this topic. So there we will cover all other questions which we have discussed till now. Again, this was a quick recall so that you can check this was for you just to check your answer. Yes, I remember there was one more question in of aortic dissection. That's also like a clinical case was given, but an easy one. So with this, we'll conclude the session. I hope you like it. See you later on with the exact perfect recall of medicine. Thank you so much. Keep working hard. Bye-bye.